So let's move on to the temporal fossa, a huge part of the face actually, which is often overlooked, and we're not aware sometimes of how much it can contribute to the aging process. A very simple and effective treatment when it comes to injecting in the temporal region, but more importantly, as I've been going on for the last 45 minutes or so, is understanding the anatomy. Now here, it's not as simple as the rest of the face where we said 5 layers, skin, fat, muscle, fat, bone. Here we've got 10 layers, starting off with the skin and then moving on into the fat and the different fascias, muscle, and then periosteum. Now, a nice way to remember this is if you look at the list on the left hand side. So just work with me here. Okay. So we have skin, then we have fat, fascia, fat, fascia, fat, fascia, fat, muscle, bone. So if you remember this, you will never go wrong. It might take you a couple of seconds to try and figure out which fascia or which fat pad you're in. However, that's a nice way of trying to learn how you will work your way from skin right down to periosteum. Now, I'm not going to go into too much detail on this webinar regarding this because it's something I'm going to be talking about in Vancouver, where I will hopefully also be using ultrasound to highlight where the blood vessels are. But keeping it simple, just for the sake of this presentation, we need to be aware of the superficial temporal artery, which is a branch of the external carotid artery. And this is in layer number 3, okay, which is a superficial temporal fascia. Sometimes when we use a cannula in the temporal region, if you are deep to this and you lift the cannula up, you can actually see the artery in the fascia in itself. And that is quite possible to do because the loose areolar tissue, which is layer number 4, once your cannula is in this area, it should freely move around. One way of getting into this area actually is by having an entry point actually in the forehead itself, going deep towards the galea and then heading laterally across. This will take you into the loose areolar space. Understanding margins is also very important, and again, not trying to overcomplicate things here. Keep it simple, top, bottom, front and back, if you like. More importantly, you can see the temporal fusion line. We can see the lateral aspect of the orbital rim. We can see the zygomatic bone. And this is the region in the anterior aspect of the temporal fossa where we are going to be putting the product. Now, we can see that it really isn't a posterior border. It keeps running towards the back of the skull. So this is something we need to be very cautious about in terms of product choice. So this is why now we want something with a very high G prime that is extremely cohesive. So where you put it, it practically stays in that region. As I mentioned on the forehead, 2 things. Indication, here is a hollowing. How do you safely do it? Needle or cannula, which I'll talk to you about after I've shown you a few slides here. So this is the point I was trying to make earlier on, being in layer number 4 here. So what we see here is layer number 3, which is a superficial temporal fascia, which is housing the superficial temporal artery. You can see it's quite a large caliber artery here. Just another diagram highlighting everything. The other thing that we need to be aware of is the sentinel vein or the middle temporal vein. And this has been documented in the literature. You hit this vein and you can cause quite a large hematoma. Patient won't be happy for a good few days, if not a week or so. Worst case scenario, there will be retrograde flow into the pulmonary system, and this could cause, well, a PE and eventually kill the patient, which has been documented. So just something to be aware of where this will run. Now, this is why temporal region is very high risk, because the next few slides will show you, and hopefully then you can appreciate the anatomical variation. So what you see here marked in red is the middle temporal vein, and you can see the different course it has here. It's quite curved and large in caliber. On the right hand side, it's quite acute but thin in caliber. And then again, we've got even more variation here. So you can see not any 2 faces are the same. So one way of injecting this region is, some of you may have heard of the Swift point as well, which is finding the temporal fusion line. You got one up, one across. use the needle straight onto the periosteum. That's a very effective way of injecting. Another way to do this is using a cannula, again, 25 gauge cannula being my instrument of choice. And I tend to have more of an inferior lateral entry point, which is near the hairline. And then I will work superiorly, medially into the fossa. And you've got two planes of choice here. You can be in the subcutaneous plane, or you could even be in layer number 4, which, if you remember, is the loose areolar tissue. So you've got two places where you can inject with your cannula. This, I hope this plays, so please do bear with me. We mentioned, before I try to figure this out, we mentioned the swift point, which is one up and one across from the red solid line, which I've drawn here on my patient. Another way that I like to do this, and I have been doing for many, many years, is I identify the lateral canthus, which is easier to do. And then I go 2 centimeters lateral and then 2 centimeters superior. I will then palpate the area to make sure there's no pulse. And then that would be my entry point. Just bear with me here if I can. It might not be on this one, might be the video. So 2 centimeters across, 2 centimeters superior. Just one of my patients. This is me injecting high G prime product. I palpated the area. For the sake of the video, I did aspirate, as you can see, in case any of you are wondering. And look where I have my thumb on my non-injecting hand in the hairline to prevent too much displacement posteriorly. Because if you remember the previous slide, I showed you about the borders of the temporal fossa, which aren't very strict, if you like, for use of a better word. So very slow injection. Patient is comfortable, very much relaxed. And I would have used half a cc there. So 0.5 mil is what I would have used. Can you use more? Of course, you can safely usually put around 1 mil. Most of my patients typically require 0.5 mil. Again, it depends on assessment. You don't want to put too much in and then masculinize the upper third of the face.